I'd now like to introduce our facilitator, Karen Francis.
Well, good afternoon, everyone, and welcome to today's webinar entitled Trauma-Informed Approaches to Healing for Children and Families in Rural Communities. Today's webinar is the first for the 2012 Rural Behavioral Health Webinar Series, and I'm so pleased to introduce our presenters this afternoon. Our first presenter is Ingrid Donata. She's the Chief of the Mental Health Promotion Branch at the Center for Mental Health Services at SAMHSA, and we also have Arabella Perez, who is Executive Director of Thrive Initiative in Maine. So without further ado, Ingrid, I will turn the presentation over to you.
And today, Ingrid is not on webcam, so we'll be solely focusing on the slides.
Ingrid, please press *7 to unmute your line.
Hello, can you hear me?
Yes.
Hi, as Karen mentioned, my name is Ingrid Donato. I am Chief of the Mental Health Promotion Branch of the Substance Abuse and Mental Health Services Administration. Thank you so much for joining us on this webinar on trauma-informed approaches to healing for children and families in rural communities. In a moment, we will be hearing from Arabella Perez, who, as Karen mentioned, is the Executive Director of the Thrive Initiative in Maine. But before we do, I wanted to take a moment to set the stage for this very important issue and why it plays a vital role in the work we do here at SAMHSA. I want to start by giving you a few facts about trauma, and I'm sure many of you know these already. In the U.S., a woman is beaten every 15 seconds, forcible rape every 6 minutes. And according to the Office of Women's Health, between 55 and 90% of women in substance abuse treatment and 85 to 99% of women in the public mental health system report a history of trauma. Experiencing trauma in childhood can have a severe and long-lasting effect. Children who have been traumatized see the world as a frightening and dangerous place. And when these childhood traumas are not resolved, this fundamental sense of fear and helplessness carries over into adulthood, setting the stage for possible further trauma and the potential for development of mental, emotional, and behavioral disorders. These are very particular topics of interest here at SAMHSA. According to the Adverse Childhood Experience Study, or the ACE study, one of the largest studies ever conducted to assess the associations between childhood maltreatment and later life health and well-being, found that almost 2/3 of the study participants reported at least one adverse childhood experience of physical or sexual abuse, neglect, or family dysfunction, and more than 1 in 5 reported 3 or more such experiences. The ACE study shows that the greater the number of adverse experiences, the greater the risk for negative outcomes, such as alcoholism, depression, suicide attempts, and physical problems as well, such as heart and liver disease. This study also revealed that the economic costs of untreated trauma-related alcohol and drug abuse was estimated at $161 billion, and that was back in 2000. We must realize that the vast majority of people we hope to reach with our programs have trauma histories, and this makes the understanding of trauma-informed care an imperative. Rural America is very important. Rural America has been and continues to be a vital part of the nation. 80% of the United States inhabitants live in suburban and urban areas, but cities occupy only 10% of the country. Rural areas occupy the remaining 90%. Just a working definition, rural areas comprise open country and settlements with fewer than 2,500 residents, and these residents face unique challenges. Just one of them, according to the Carsey Institute, 1 in 5 poor children live in rural communities. In many rural communities, the lack of qualified health providers is staggering. Health professional shortage area is the federal designation in which the ratio of citizens of a service area to primary care physicians is greater than 3,500 to 1, and for core mental health professionals, it is 9,000 to 1, and 30,000 to 1 for psychiatrists. And just to kind of give you perspective of how big of an issue this is, there are currently 5,856 areas designated as primary care shortage areas and 3,707 mental health shortage areas across the U.S. Adding this significant lack of accessible care with negative attitudes towards mental illness and substance abuse, the concepts that these are due to moral failings or character weaknesses, as well as negative attitudes towards help-seeking behavior, highlight how important it is to develop strategies and promote services and programs in rural environments. I had the opportunity to meet with a couple of kids featured in the recently released documentary Bully. This movie follows the lives of a number of kids, some from rural communities, who are being seriously bullied in school and in their community for seeming different. Shelby, who is one of the females highlighted, recently came out as gay and went from being a popular athlete to being completely ostracized. Alex, who, if you have any familiarity with the movie, is the boy who is featured most prominently as a boy with Asperger's, struggling to understand why kids are so cruel to him. Both are now celebrities and flourishing in their with all the paparazzi around them and their new role as spokespeople for bullying prevention. But they really helped put a human perspective on the isolation and the misconceptions that can shroud those struggling and their families. Conversely, the strength of rural communities can be the sense of shared responsibility for the community, schools, churches, community leaders often reaching out of their particular designations to become natural helpers. I met with tribal elders in Montana who showed me how often the person who identifies a child or an individual in need is also the same person doing the screening. They'll refer that person to themselves, they will do the treatment themselves, and then likely they will drive that person home because that's so-and-so's kid that lives down the street from them. SAMHSA is deeply committed to the issues of trauma and the struggles facing those in rural communities. In aiming to accomplish our mission of reducing the impact of substance abuse and mental illness on America's communities, SAMHSA has outlined 8 strategic initiatives. The first, the prevention of substance abuse and mental illness, strives to create communities where individuals, families, schools, faith-based organizations, and workplaces take action to promote emotional health and reduce the likelihood of mental illness, substance abuse, including tobacco and suicide. The second strategic initiative is trauma and justice, reducing the pervasive, harmful, and costly health impacts of violence and trauma by integrating trauma-informed approaches throughout health, behavioral health, and related systems, and addressing the behavioral health needs of people involved in or at risk of involvement in the criminal and justice systems. So when you think about that, when we're outlining SAMHSA's mission, what we wanted to do, the number one and number 2 priorities, initiatives within SAMHSA are to prevent mental illness and trauma and justice, just showing how important these issues are to us at SAMHSA. Now, SAMHSA has a wide range of programs and efforts to address these initiatives. One of the biggest ones out of our division, the National Center for Traumatic Stress Initiative, is a collaboration of academic and community-based service centers whose mission is to raise the standard of care and increase access to services for traumatized children and their families across the United States. We also have our Crisis Counseling Assistance Program, our publication warehouse, where you will find an array of resources on trauma-informed care, and the National Registry of Evidence-Based Programs and Practices, which we call NREP, which houses a number of trauma-informed programs. I urge you to visit our website, samhsa.gov, and National Center for Traumatic Stress website, nctsn.org, where you will find a wealth of resources for these particular issues. Before we move on to Arabella Perez, and one of the reasons why I was so thrilled that I was offered the opportunity to provide some opening comments, is that I would like you to briefly highlight a couple of the programs within the mental health promotion branch. Next slide, please. And before we go on, go ahead.
Hi, Ingrid. So we're going to do 2 polling questions before we get into the rest of your presentation.
Sounds great.
So our first one, this is for participation from our audience. The question is your community or program using public health strategies to prevent mental illness and substance abuse in children, youth, and young adults? Your options are: we are 100% focused on prevention and understand that risk and protective factors impact multiple disorders. Second one is: prevention is well embedded, but it is not systematic. Third, we are doing some prevention work, but it is very fragmented. And then lastly, prevention is not a priority for our community or program. Our funding priorities are with treatment. And then also, of course, not applicable. So far, it looks like those people are with we are doing some prevention work, but it is very fragmented.
I am thrilled that there are so little in the green category. You know, the real focus of our branch is prevention. We're going to go a little bit into our core concepts that we base on. And actually here at SAMHSA, we are really trying to do a lot more work in working with the states, working with communities about developing prevention infrastructures and really trying to take those next steps into integrating prevention into the basic foundations, trying to steer away from treatment, you know, which is very, very important, but really giving the onus of responsibility into prevention to really kind of get things before they become illnesses. So I am thrilled that there are so many at least starting some prevention work. Okay.
Okay, great. I think we're ready for our second polling question. And then this is kind of just to see where everyone's knowledge is. What are the core concepts of prevention? We have developmental perspective is key. Mental, emotional, and behavioral disorders are developmental. Mental health and physical health are inseparable. Successful prevention is inherently interdisciplinary. Coordinated community-level systems are needed to support young people. Prevention requires a paradigm shift. And then lastly, all of the above. I believe you can change your answer if you want.
I noticed that. It looks like we have a very smart group here.
Okay, looks like we are at all of the above.
Wonderful, wonderful, and that is absolutely correct, as you will find out as we go into our next slide whenever you're ready. Okay, wonderful. This is really the basic foundation of the work within our branch, the core concepts of prevention. Number one, prevention requires a paradigm shift. The prevention of mental, emotional, and behavioral disorders inherently involves a way of thinking that goes beyond the traditional disease model where you wait for the illness to occur. Prevention focuses on the question, what will be good for the child 5, 10, or more years from now. You will see the maximal effects of treatment right after the delivery of treatment, but this isn't the case with prevention. We need to be able to tolerate the lack of immediate results in exchange for the more profound and long-lasting effects of prevention programs and practices. The second core concept, mental health and physical health, are inseparable. The prevention of mental, emotional, and behavioral disorders and physical disorders, and the promotion of mental health and physical health are inseparable. Young people who grow up in good physical health are more likely to have good mental health. This is a very core concept with us at SAMHSA. Number three, successful prevention is inherently interdisciplinary. No agency, no program, no policy alone will work. We must break down silos and work collaboratively. Long-term gains of prevention efforts are yielded not only in the mental health and substance abuse systems, but also in justice, education, welfare, etc. Number four, mental, emotional, and behavioral disorders are developmental. The health status of young people has a significant influence on the trajectory of health into adulthood. While research suggests that the early years of life are one of the most opportune to affect change and an area in which we particularly target we try to, other developmental periods such as early adolescence and different settings such as schools provide opportunities for interventions. Children develop in the context of their families, their schools, and their communities. And number 5, coordinated community-level systems are needed to support young people. Supporting the development of children requires that infrastructure be in place in one or more systems: public health, healthcare, education, community agencies. The benefits of prevention may occur in a system other than the one that paid for the prevention activity. It is so important for us to learn how to play well in the sandbox. This is crucial to really these prevention activities. And overarching developmental perspective is the key. Let's get ahead of these disorders. Let's see what we can do about minimizing risk factors, maximizing protective factors. Next slide, please. And you'll see up in the corner there a little blue book, Preventing Mental, Emotional, and Behavioral Disorders Among Young People. This is a report from the National Council Institute of Medicine, which was created in 2009. It really is the foundation of our work within our mental health promotion branch. I highly recommend you take a peek at it. It really outlines key prevention and promotion concepts and how we as a nation can work to achieve them. Well-designed prevention interventions work. Prevention and wellness interventions can have multiple benefits that extend beyond a single disorder. We get these prevention programs in place when they were young, and before disorders start, you can see that we'll have a chance of minimizing depression, anxiety, substance abuse, a whole constellation of disorders. And the key, as I mentioned, is to identify risks that may increase a child's risk of mental, emotional, and behavioral health disorders, and to minimize them and maximize those protective factors. In rural environments, we want to think about the lack of the difficulty in access to care. We want to maximize the sense of community that can happen and how natural helpers can step up to the plate. Can you do the next slide, please? And this is our hope, a future founded on prevention, that families and children have access to the best available evidence-based prevention intervention delivered in their communities in a culturally competent and respectful way. That prevention interventions are provided as a routine component of school, health, and community service systems. We want mental health in primary care. We want it in the school. We want to have these great access to care. Children and families have multiple points of entry for preventive services. We want to go to where the children and the families are, not having them wait to come on in to go see a therapist. Let's go to where the kids are in our branch. That we do an extensive amount of work within school systems, and you'll see because that's where the kids are. So before I discuss, and we're going to go into the, if you go on the next slide real quickly, this is a map of the urban-rural classification. I outlined, the next few slides are maps, the grantee maps about where our programs are located, our grantees are located. But I wanted to have you have this visual so you can conceptualize where the urban and rural populations are located. The white part is the urban area. And so if we go on to the next slide, I want to talk about one of our programs. I'm going to go over a number of them. Project Launch. This is a major grant program within our branch. It is a cooperative grant program that seeks to ensure that all young children, especially those at increased risk for developing social, emotional, and behavioral problems, receive the support they need to succeed. This investment in the healthy physical, social, emotional, cognitive, and behavioral development of young children forms the foundation for later successes in school and life and serves to protect against negative outcomes such as school dropout, drug and alcohol abuse. This is a common theme. At the state, tribal, and local level, Project Launch brings together stakeholders to develop a vision and a comprehensive strategic plan for promoting the wellness of all young children. It revolves around 5 core strategies: the use of developmental assessments in a range of child-serving settings, the integration of behavioral health in primary care, mental health consultation in early care and education, enhanced home visiting through increased focus on social and emotional well-being, family strengthening, and parent training skills. And the outcomes have been pretty good, pretty impressive actually. Since its inception, grantees have screened and assessed more than 49,000 children and parents. 2,204 families have been served through home visiting programs. 4,800 families have served through family strengthening programs. And 11,000 community providers have been trained in social and emotional behavioral health. I wanted to highlight a particularly interesting example of project launch in action in a rural environment. In Washington County, Maine, which is located in the northeast corner and is very rural, a grantee from the first cohort of launch has made tremendous strides with high-risk pregnant mothers, specifically with those who became pregnant while on methadone maintenance and had babies that had withdrawal symptoms. They developed a bridging program to help prep these moms before they had their children on what to expect in the NICU, as well as to set up wraparound services which put natural helpers in place to support these moms and new babies, things like finding transportation to and from the hospital, working to make sure that the kids are at home or being watched after, all the things that would hinder a new mom and her baby from getting the critical care that they needed to ensure healthy development. And they found a significant reduction in rehospitalization rates. They also there've never been a developmental pediatrician in the county. Through the grant, they were able to get one in there to come in twice a month to do developmental assessments and treatment plans. They work with 2 tribal reservations in the county and have tribal representation on the state level. They do a significant amount of bridging work to help leverage resources. This is key, and we're able to actually save home visiting in the state, which is, for those in the rural communities, this is a much-needed resource for rural communities who can struggle with transportation issues. Next slide, please. Another one of our grant programs is called Prevention Practices in School. 21 grants have been awarded to school districts in which at least 50% or more of the students qualify for free or reduced lunch. PPS funds schools to train staff and implement one of the most researched evidence-based programs, the Good Behavior Game. There has been extensive amount of research on this particular program, and studies have shown that in the short term, there's reductions in early aggressive and disruptive behaviors in the classroom. Socialization within children improves, and teachers are able to create a positive learning environment. And in long-term follow-up studies, there was a very significant one in Baltimore City, but there have been so many additional ones. They found that by children who have been exposed to the Good Behavior Game have reduced drug and alcohol abuse. They have reduced antisocial personality disorder, reduced incidents of suicidal ideation, reduced smoking, increased graduation rates. It's really amazing. And one of the interesting rural success stories within this grant program occurs in Wheatland, California, which is a rural area with approximate population of about 3,000. It's located in Yuba County, which is notorious for a very high prevalence of meth and alcohol use. Wheatland is isolated, disconnected from resources by the closest cities of Sacramento and Yuba City. The school population, interestingly enough, is made up of a high percentage of military families from a nearby Air Force base, as well as farmer and migrant farmer worker families. Due to the high ratio of unincorporated land, there is a low police presence in the county, although there is a high parolee rates. The Wheatland School District, and notably Bear River School, have in place a solid prevention infrastructure and have been able to sustain grant programs in various areas for over 10 years. Bear River also offers supports to its children through a family resource center that helps the families to access county and area resources, which helps address that isolation factor which happens in highly rural environments. The Good Behavior Game has been successfully implemented in the Bear River School. Currently, there have been 7 teachers and coaches trained, and in the fall of 2012, the school will be splitting up into K through 3 and 4 through 8. GBG will be implemented in the entire K through 3 program and implemented in the 4th grade as well. The Bear River School population is about 810, out of which roughly 150 have been exposed to this classroom intervention. And during the 2011-2012 school year, the second grade classrooms have reported zero behavioral related referrals, which is really impressive. Next slide, please. And the largest of our grant programs is our Safe Schools, Healthy Students Initiative in FY99. Congress had appropriated $1.7 million for an unprecedented collaboration between the Departments of Education, Health and Human Services, and Justice. It's three departments working together. Through this collaboration, the department has developed a program to support school and community partnerships in their efforts to integrate systems that promote the mental health of students, enhance academic achievement, prevention of violence and substance use, and the creation of safe and respectful school climates. Safe Schools takes a broad approach. It draws on the best practices in education, justice, social service, and mental health, as I mentioned earlier, breaking down those silos to help communities take action, teaching these different areas to work together. It provides grant funds, technical assistance, and evaluation, which looks at both process and outcome measures. It's based on three key elements: to create safe school environment and prevent violence, to deliver alcohol, tobacco, and drug prevention programs and early intervention programs, to provide and promote student behavioral, social, and emotional supports, to promote school and community mental health services, and to provide early childhood social emotional learning programs. The outcomes of also, there was a national cross-site evaluation of the Safe Schools, Healthy Students Initiatives, which found that students received school-based services increased by 263%. Students receiving community-based services increased by 519%. 96% of school staff reported that Safe Schools Healthy Students has improved school safety, and more than 90% reported that Safe Schools has resulted in less violence on their school campuses. Nearly 90% of school staff stated that they were better able to detect mental health problems in their students, and more than 80% of school staff reported that they saw reductions in alcohol and other drug use among their students. And again, I want to highlight a very interesting rural grantee. As part of their Safe Schools, Healthy Schools project, Nevada County put their family resource centers into schools to ensure utilization and reinforce the notion of schools as a community resource or hub of community activity in rural areas. These family resource centers provide family support services by creating a central location for health, mental health, educational, and recreational services. As one-stop service and referral organizations, family resource centers are designed to control service duplication and to encourage community involvement and cross-generational relationships. These family resource centers promote community connections that empower families and enhance our lives of young children. Most of these centers throughout Safe Schools provide core services like medical care, counseling, parenting classes, literacy classes, referrals for child care and specialty medical services, and direct contact with early childhood and child development programs, including Head Start and home visiting. Again, you'll see working across services. Next slide. And I'm almost done, and we'll be able to get on to Arabella. So what can you do if you do not have a Safe Schools grant? As a grant-issuing organization, grants are typically issued once a year, as many of you know, when funds are available from Congress. But what we have done through all of the lessons that have been learned through the Safe Schools Healthy Students initiative was to create an online toolkit that is available to anyone across the nation, which really synthesizes all of the lessons learned into an easy-to-use toolkit. It's for community leaders who have huge budgets to community leaders who have zero budget, so they can integrate all of these lessons learned throughout the Safe Schools Healthy Students initiative. So I'm very grateful for this opportunity to be able to give you a little peek into the work that we do in the Mental Health Promotion Branch, and to kind of give you a little snapshot about how important this work is to SAMHSA, and we're very excited and glad that you're all very interested in this particular topic. So thank you so much. I think next will be Arabella Perez.
Thank you, Ingrid. That was really wonderful. Now we have a time for questions, and we do have one question that was submitted to us.
Okay.
And the question is, where can communities of faith be part of a comprehensive and inclusive engagement of prevention?
I'm sorry, could you repeat that again? I didn't hear it.
It says, where can communities of faith be part of a comprehensive and inclusive engagement of prevention?
Yeah, how can?
Yeah, how can?
Oh, how can they? Well, that's really one of the things that we're working on right now extensively is to develop the tools needed to develop state level, community level prevention infrastructures. This is something that we're working on right now to develop the tools to do this. If you go on to the SAMHSA website, if you click on the very first initiative, which is prevention, you'll be able to have access to different tools, different products that you can use to start conceptualizing about developing a prevention infrastructure. I highly recommend that you start by looking at the IOM report, that little blue book, Preventing Mental, Emotional, and Behavioral Disorders Among Young People. It is a really great starting point for really looking at issues about developing prevention infrastructures, where to start, what different communities do, and it will give you a little snapshot about what we in the federal government, how we are starting to work on that. You can go to our various websites. Definitely check out the Safe Schools one, where we're starting to really try to figure out how to take the lessons from our prevention grant programs and bring them to scale nationally to have these tools that are available to states and communities to start on their infrastructures. So stay tuned. Please check the SAMHSA website often. We will be having all sorts of information about that.
Okay, great. So if we have any other questions, you can press *7 on your phone to unmute your line. Okay, I think we're ready now for Arabella. So Arabella, you can do *7 to unmute your line, and Ingrid, *6 to mute yours. And we'll put Arabella onto the video cam. And this is a good point to remind everyone that since the presenters are using webcams during this event, the quality of the video depends on your internet speed. If you find the video disruptive, please feel free to click the X in the voice and video box to close it. So Arabella, we are ready for you.
Can't hear her.
Arabella, you need to press *7.
Still can't hear her.
Arabella? Ooh, okay, one moment.
All right, how about now?
Okay, we got you now.
It was a combination of buttons and pressing them the right way. So,
okay, we have you now.
Yeah, good afternoon, everyone. And thank you so much, Ingrid. I really appreciate the platform that you were able to set for this conversation. It was very exciting to hear you speak so eloquently and so quickly on so much. And I feel like I have a lot to share as well, and I'm very excited to be presenting on this topic that I'm very passionate about. So what I want to start off with first is sharing with you what the agenda is and what I hope to accomplish at least in the next 40 minutes, which is to really sort of review with you what are those trauma-informed principles and what do we mean when we say trauma-informed, and to also share with you our own research findings here in Maine and how that's really informed the work that we do and how we've sustained that work through assessment and through continuous quality improvement. Before I move on to the next slide, I also wanted to thank Ingrid for sort of giving a shout-out to Washington County, Maine, and Project Launch. The project director there, Marjorie Withers, is a strong trauma-informed champion. And when I think about the other initiatives in our state, like our Safe Schools, Healthy Students, we have a national child traumatic stress network site as well. We also had a Robert Wood Johnson grant that was working with refugee children who experienced trauma in the educational system. And what we all had in common was a desire to really look at this work through a trauma-informed lens and to work collaboratively together. And I can't stress enough the importance of partners across all of those systems, that it's not just behavioral health, mental health, but it's those other systems as well. So as I speak, I think about all the work those other project directors have brought to the table and their willingness to learn from each other. So I wanted to share that. The second piece I wanted to share is when we first started doing this work about 7 years ago, and actually I'll let you go to the next slide here. When we first started doing this work 7 years ago when we were funded, it was very interesting when I would be in a room with other project directors, other principal investigators, other stakeholders from other states outside of Maine, and I would talk about being a trauma-informed system of care. I would hear from them, well, we are also a trauma-informed system of care. And I thought, great, there's other people. So I'd ask them, what is it about your system that's trauma-informed? And what they would share with me is that, well, we provide an evidence-based treatment, like trauma-focused cognitive behavioral therapy. And my response would be, great, and what else do you do? And generally, that's where the conversation ended. So we've come a long way. Now when I enter a room and I talk about a trauma-informed system of care and other people say to me, well, we also are a trauma-informed system of care, and I have that same question, now I hear, we provide education. We know the impact. We work with everyone. It's not just in the clinical area. So we've come a long way, and that's really exciting for me. So in this particular slide here, for those of you that are familiar with system of care, those principles of family-driven, youth-guided, and cultural linguistic competency guide our work. They're the core of who we are. In Maine, what we've done is we've added a fourth principle, which we call our system of care principle, and that's trauma-informed. So I often equate it to you have a three-legged stool or you have a four-legged chair. My hope is that it's a strong chair. So by being trauma-informed, you're enhancing those other three principles. And I would say that many of our family and youth have said that being trauma-informed has allowed them to break free of the stigma and really sort of recognizing how broad and general trauma is and how it really is pervasive and how to create opportunities for resiliency and hope. So trauma-informed for us is our fourth principle. We graduated the system of care in the fall of 2011, and now we're an independent nonprofit. So what we do here in Maine and outside of Maine is we provide training and technical assistance to other communities, to agencies who want to take on this journey of being trauma-informed. And it's very exciting to work with other states. We've worked with Southern Indiana, we've been working with Plainview, Texas, we've worked with Missouri, and to really see these states embrace those principles and take it to the next level is very exciting. And many of those communities have taken it beyond what we've done here in Maine. So I love that. So the next slide, please. So why be trauma-informed? Well, one of the things that happened early on when the state of Maine applied for the System of Care grant 7.5 years ago was Dr. Jay Yo, who is the director of the Office of Quality Improvement, had decided to look at data along with the director of Children's Behavioral Health Services, Joan Smirsky, sort of looking at children who were receiving targeted case management services, who really were high needs and were utilizing many, many services here in Maine. And one of the things that he did in looking at that research is he found that children and youth that were trauma survivors were at greater risk of significant harm, were likely to experience co-occurring challenges, had significantly greater challenges in the areas of child, youth, and parent-caregiver acceptance and engagement with service providers. That was really important as well, because oftentimes we hear the term that someone is resistant to treatment. Again, looking at it from a trauma-informed lens, and Dr. Yo's research really just sort of gave us the proof that we needed, which was to say engagement is especially difficult for a family, for a young person who's experienced trauma, and trust is one of those principles that I'll get to. We were also able to see that these youth and children are more likely to use mental health services and high-end services for greater periods of time. And they had 73% higher mental health service expenditures and 51% higher overall treatment expenditures compared to youth that did not have that trauma history. So very compelling information. I know that Ingrid also touched on that. So here in Maine, that bears out. The other piece here to recognize is that children and youth react to trauma differently than adults. I am a trained clinician, and when I thought about trauma 20 years ago, I thought about post-traumatic stress disorder and the symptoms, the cluster. Then I started working with children and youth, and rarely would I use that as a diagnosis. So what we also know, and we know this from research, and the research is cited there, is that children and youth who experience trauma are less likely to receive a formal PTSD diagnosis. No surprise there for me. And if I were to do a polling question, usually when I do this training with an audience, I will ask them, what are some of those diagnoses, some of those labels, some of those symptoms that you see in the population that you're serving? And what invariably I will hear will be attention deficit hyperactivity disorder, oppositional defiant disorder, mood disorder. So we know that a large portion of these children that have experienced trauma manifest trauma in very different ways, and that oftentimes that diagnosis doesn't get them the treatment that they need. And we know that early treatment, effective treatment, will lead to better outcomes. So that's the piece there. And lastly, we also heard Ingrid talk about adverse childhood experiences, so I won't go too in-depth just for the sake of time, but finding that strong relationship between exposure to trauma during childhood and risk factors for health and social problems later on in life. So next slide, please. And here you have the pyramid. So for those of you that have seen it before and those that haven't, this is the Adverse Childhood Experiences Study, and you can actually go to their website, which is www.acestudy.org, and it's cited there. I can see from the slide you might have difficulty reading that arrow. And what that arrow is saying, what's going up and down, is whole life perspective. At the top is death, and at the bottom is conception. So thinking about from birth to death, and then that journey is that whole life perspective. And as we look at that, and again, this is the work that Dr. Salidi did with the Centers for Disease Control in Kaiser Permanente in San Diego, was to really look at those adverse childhood experiences. And some examples of those would be recurrent physical abuse, recurrent emotional abuse, sexual abuse, incarceration, alcohol or drug use problems, mental health issues of a household member, domestic violence in the household, death of a parent. And he found that the more number of experiences prior to the age of 18 led to social, emotional, and cognitive impairment, led to the adoption of health risk behaviors. And again, if it were a polling question, what might you consider those health risk behaviors? Certainly substance abuse falls into one of them, tobacco dependency. And from a trauma-informed perspective, when I look at health risk behaviors, I see those as adaptive skills, ways of trying to make sense and of coping with the trauma. But what we know is the adoption of health risk behaviors leads to disease, disability, and social problems, and early death. So, as Ingrid also mentioned earlier, from a cost-benefit analysis, it's imperative that we address this early on from that prevention standpoint, that early intervention and treatment, so that we can really take better care of ourselves and our community. So, next slide, please.
Okay, we are ready for our third and final polling question. The question is, the most pressing trauma-related issue in my community over the past year has been natural disaster or events, gun violence, discrimination, childhood trauma, domestic violence, and then lastly, I am not aware of how trauma impacts my community. So it looks like we have most people falling to childhood trauma. No, domestic violence.
Childhood trauma.
It looks like almost half with childhood trauma, 41% domestic violence, a little bit of representation from gun violence, discrimination, and not being aware of trauma, how it impacts their community.
So the majority is childhood trauma.
Okay, I think we're pretty final.
So what I'd like to just say in terms of that polling question is when we first started doing this work, we would define trauma. We would use the definitions that were out there. One of the ones that we would use came directly from the National Association of State Mental Health Project Directors. And in talking to many of our family and youth, it was important for us to hear from them how they define trauma. And how they define trauma was very much a broad, general description of distressing events that are troubling, that impact functioning, that are very personal to them, and that can include many of the issues that we just saw on the polling questions, And also issues such as historical trauma, intergenerational trauma, and even stigma trauma. We talked about bullying earlier. So really looking at how trauma has been redefined over time, and asking our family and youth, what is trauma to you? Because knowing that it's a very personal experience. So it was important for us to look at it through that broad lens. So thank you for sharing what you did with the polling question, and I wanted to put that out there. With this particular slide here, so now getting into trauma-informed and that trauma-informed theory. So I always give credit where credit is due, and this work would not be possible without the work of Roger Fallon and Maxine Harris. And they wrote a very small book called Using Trauma Theory to Design Service Systems. And this came out of Community Connections in D.C., where they were working with adult consumers, primarily women. And in the course of their work, sort of recognizing that something was missing. Something was missing for these women. And what was missing was this. Instead of asking what's wrong with you, the trauma-informed approach asks what has happened to you. And I pause there. And what I say to people is, this really to me is what being trauma-informed is in a nutshell. And you don't have to be a clinician either. This really is about having a holistic perspective and recognizing that everyone has a story, and the story is unique to them. Now, as I say this, that asking part doesn't have to be me literally asking. It's about an awareness. It's about interacting with individuals, whether it's that family or youth that receive services from me, or it's my colleague or a supervisee or my pastor or that Girl Scout leader. It's always in the back of my mind thinking to myself, what's the story there? And that story can be very healing. So that, to me, is really the beauty of trauma-informed, is that it's pertinent to all of us. The last piece that I'll leave you with is that to be trauma-informed is to adopt a universal precautionary approach. And when we think about universal precautions, or at least when I think of it, I think about hand washing. And why do we do hand washing? It's to prevent the spreading of germs. Now, I'm not saying that trauma is a germ, although it certainly feels like it at times. What I'm saying is that you're assuming that everyone you come into contact with has experienced trauma until proven otherwise. And being able to take that universal precautionary approach allows you to enter a relationship in a very respectful manner where you're mindful of the what's happened piece. So that's what I'd like to leave you with. Next slide. So normally when I do this, I can spend an entire afternoon just on these actual 6 domains. And I don't have an afternoon to spend with you. So what I would want to leave you with here is just, briefly describing to you what these 6 domains are. And the first 5 listed, really come directly out of Roger Fallon and Maxine Harris. And the last one is specific to us here in Maine. And again, thinking about the population that Roger Fallon and Maxine Harris were writing about was adults. So one of the things that we knew here in Maine is that we wanted to sit down with our families and have them define what those domains, what those principles meant to them. So I'll start off with safety here. So, we heard earlier of the importance of safety, and because trauma inherently involves a physical or an emotional threat to one's sense of self, families and youth are often especially attuned to signals of possible danger. So it's essential that service organizations prioritize safety as a guiding principle for trauma survivors in order to avoid inadvertently re-traumatizing them. And I say that because I know there are many providers that aren't seeking to actually re-traumatize, but they inadvertently do so by not being consciously aware of safety. And when I talk about safety, when I talk about all of these domains, it's not just family and youth. I'm also talking about other individuals. It could be the staff there, it could be adult consumers, it could be the community at large. So how do you create safety? A really good example of safety is I just got back from doing a training in Plainview, Texas, and we talked about this particular domain. We asked for examples, and we had someone from juvenile justice give an amazing example of how she was trauma-informed with regards to this particular domain. And when we asked her for the example, what she shared is she was working in a facility, a lockdown facility, and there was a young man who wasn't sleeping at night. And it took her a while. She was developing that trust and that engagement, and she was thinking about not what's wrong with you, but what happened. And in the course of having the conversation, discovered that this young man had been sexually abused at night, so he was fearful of the dark, and he also happened to share his space with someone else. So in meeting with him, they talked about what they could do, and knowing that choice was limited because of the facility he was in, trying to develop some choice even in those limitations. And one of the things they landed on was using a nightlight. And because this individual was being so trauma-informed without even realizing it, she also realized that she wanted this young man to also feel empowered and not to feel somehow like the only young person who had a nightlight in his room. So they decided to make a policy that nightlights would be available to all youth in their room, and the youth can choose whether or not to use it. So as she shared that story, I thought to myself, what an excellent example of those domains and how they were touching on each other, and how she was really able to create a safe space for that young man so that the healing could continue. And again, the beauty of that is that she didn't have to be a clinician. It wasn't within the context of an outpatient or a home visit service. It really was just a caring adult being very trauma-informed and asking questions and figuring out how to create a plan with that young man as an equal colleague. So the next domain here is trustworthiness. So again, knowing that survivors of trauma report a violation of boundaries and an inability to trust others. And I shared with you research that Dr. Jay Yo did that essentially showed that engagement was very challenging for families and youth. And oftentimes providers would label them as resistant to treatment when in fact what was happening is that they had difficulty trusting the system. And oftentimes when we think about historical trauma, especially for individuals that are African American or Native American or immigrants that have come here from Mexico, how do you trust a provider when there's been some historical baggage that has shown that providers haven't always been trustworthy? How do you do that in a very intentional way? Our youth often say that trust is the hardest of all the principles to gain and the easiest one to lose. And I would say that's quite true. As a provider, I can think of times where I took trust for granted. I assumed that it was there because someone was seeking services from me, and oftentimes we assume that trust is there and we take it for granted. And then once the trust was developed, really needing to tend to that trust constantly. So that's trustworthiness. The following one is choice. So it's really about maximizing family and youth choice and mutuality. And it's important here to stress mutuality, knowing that we're talking about youth, and many of them nested within family structures, and how to create the choice and the mutuality with shared power among them, while acknowledging the parent and caregiver's role as a parent and caregiver. So that's the piece about choice. So examples of choice are really as simple as allowing youth and family to decide who they want to see, when they want to see them, where they want to see them, having an active voice in determining treatment. And then I gave you an example earlier, even within juvenile justice, where there seemingly is not choice. How can you develop choice? So it could be a little challenging to think about that, and yet there are ways to do that. So this is where it's really important to sort of bring together other like-minded individuals to help brainstorm some ideas around this. The next one's collaboration. So here we're talking about policies, practices, and relationships that encourage empowerment, partnership, and participation, as well as strength-based and community-based approaches. So really acknowledging that family and youth have expertise, have that story, and collaborating with them effectively can certainly lead to better services. The next is empowerment. What's interesting about empowerment is when we met with many of our youth, what they would say to us is, when you speak of empowerment, it sounds as if you're empowering me. So you're assuming that I wasn't empowered to begin with. And that's a really important point to make here, because I think oftentimes empowerment isn't completely understood or well thought out. In a trauma-informed system, what empowerment means is that you provide opportunities for a youth or a family member to practice that empowerment. So another example is a training that we did for residential providers here in Maine, and at the end of it, they had to create an action plan, and they were looking at the domains, and they were trying to figure out, what can we do within our own system. And when it came to empowerment, this particular table wanted to share their example because they were so excited, and what they had shared is that they had a staff person resign, so there was an opening, and they were advertising, and there was a young woman who lived in that group home, and she clearly was showing leadership skills, and in some ways asking to be placed in leadership role. So what they decided was to have her be part of the interview team, to have her actually interview the candidates applying for that position, because who better than a resident to say to the team, yes, I think that person is a good match for us, you know. So to me, that's an example of how you take that domain of empowerment and operationalize it in a way where you're creating opportunities. Other examples would be creating advisory councils, having seats on board of directors, having youth and family review policies and procedures for a program. So again, providing those opportunities. And the last one that I mentioned earlier was we created specifically here in Maine was language access and cultural competency. So in talking to Roger Fowler, it's very clear that this particular domain really is woven through the first five that I mentioned, but we wanted to set it aside. We wanted to really name it for what it was worth. Otherwise, we were concerned that it would be left off the radar screen. And for us here, again, it's sort of acknowledging the importance of recognizing culture and how trauma intersects culture and how trauma can also destroy culture. So we wanted to be able to have a meaningful conversation about that. And then we also wanted to define culture broadly. So just as we've defined trauma broadly, defining culture, especially here in Maine, where it's a very, very, very rural state, older population here, very poor population, significant issues around substance abuse. When we look at culture, we define it very broadly. And then for language access, you know, oftentimes when we talk about language access, the first thing that might come to mind is interpretation, translation services. And yes, that certainly is part of language access and having policies and procedures that support that. Here in Maine, above and beyond that, you know, one of the examples that we give is when you seek services. And it doesn't even have to be mental health services. You could just be seeing your physician who's giving you a bunch of information to sign about HIPAA. But as you get that paperwork, it could feel very daunting, and already you're feeling vulnerable. You have a trauma history, so you're sitting there with the information. So it's all about how do you present that information. So when we do education around being trauma-informed, we actually talk to support staff, and we ask them, how do you do that? And you know, a trauma-informed way to do that would be to say to an individual, here's a pack. I know there's a lot of information here. It could be overwhelming. There's some ways that we can go about completing this. You and I can do it together. You can take it home and bring it back. You can do it now. The beauty of that is, you know, some support staff would say to us, well, I would ask them, do they want me to read it to them, assuming that maybe they can't read. Well, upon reflection, what the support staff were able to realize is that there's shame associated with not being able to read that. So how do you do it in a way that's respectful? So that individual doesn't walk out feeling shamed. So to us, language access is more than just the actual language being spoken, but just ease of understanding in different ways and modalities of understanding. That's the sixth one. Next slide, please. So here, I mentioned earlier, and I gave the example of being trauma-informed versus being trauma-specific. And oftentimes when I would have this conversation with people, they'd be really great at identifying that trauma-specific treatment. And trauma-specific treatments have a place in trauma-informed systems, absolutely. When I think about this work, I think of trauma-informed as my foundation. And then what I build off of it are the specific elements. So to be trauma-informed is to really look at that universal precautionary approach, to understanding that service relationship and not taking trust for granted, and to always tend to that. Looking at those policies and practices. So here we're talking about, you know, incorporating knowledge about trauma, its prevalence, impact, recovery, and again, not just from the clinical standpoint, but from everyone. So whether you're the receptionist, whether you're maintenance staff, you could be members of the board of director, you could be the resource officer at the school, the teacher, the juvenile justice correction officer. Everyone can benefit from this information. So really incorporating that knowledge in the broadest sense, you know, utilizing trauma screening tools. And you can go to the National Child Traumatic Stress Network website, find different screening tools, find different assessments. I think what's important is that you find something, you pick something. So even if you have a screening or an assessment that you're currently using, are you asking some key questions about trauma? Because we also know that by not asking about the trauma, and we hear this from the adult consumer movement, is it perpetuates that trauma is a secret. and that we're not to talk about it. So it's important that we find ways and that we also support staff in being able to ask those questions. I've done many trainings on trauma-focused cognitive behavioral therapy, and there was one in particular where after the training, a particular supervisor came up to me and said, I don't think that the clinician that I supervise can do this because it's triggering her stuff. And I thought that that was great. He was being a trauma-informed supervisor, realizing that this work was too close to home for that individual, and that was really important. Then under trauma-specific, we have those evidence-based treatment models. And again, you can go to the National Child Traumatic Stress Network and read more about those. I won't go into length. I've been talking about trauma-focused cognitive behavioral therapy. There's others that meet the gold standards. There's some that are promising practice. And again, the beauty of that is when you do that trauma-specific treatment, embedding it in a trauma-informed system, the outcomes are better. If I provide really good trauma-focused cognitive behavioral therapy and the young person then leaves my office and has an experience with a receptionist because they've missed 3 psychiatric appointments, now their case is going to be closed, and that young person feels shamed and blamed. They walk out, they have a meeting with their juvenile justice correction officer who doesn't know the work we've been doing and also isn't thinking about the trauma, isn't asking those questions. I mean, I can go on and on, but what I'm getting at is that I could do really, really good trauma-specific treatment, and it can be unraveled. It can be unraveled because of the other individuals around the system. And again, it doesn't mean that they're doing it intentionally or not. It just means that if they had received that education, it would have supported that trauma specifically. So next slide, please. And now we're going to talk about the impact of trauma on children and families. So this is the data stuff. So next slide, please. I'm not an evaluator, but I've heard our evaluators speak enough on this. So if we go to the next slide, you'll see here, these were the local evaluation questions that we started off, that we wanted to ask of ourselves. So what we wanted to do was to get at the incidence and prevalence of trauma exposure. What was the prevalence in children and youth who were enrolled in Thrive? What was the prevalence of trauma experiences of the families of those children? And then the second prong approach was the effectiveness of trauma-informed approaches to services. So to what extent did children and youth enrolled in Thrive system of care exhibit reductions in trauma-related symptoms? Next slide, please. So these are the evaluation study participants, family and children and youth up to 18, who live within the Tri-County area. So here in Maine, we're talking about western Maine. If you were to divide Maine into 3 parts, the first part being southern Maine and the top part being northern, we're right in the middle, covering from New Hampshire to the coast. And it's an area where it is primarily rural with one urban center. Also looking at youth that were involved with at least 2 systems. Those 2 systems could be either child welfare, juvenile justice, children's behavioral health services, or education. So being involved with at least 2 systems, having a serious emotional diagnosis. And these were families that were matched with a family support partner. And that was a very important piece for us, knowing that it's that peer support that's crucial for families, and we'll get to why when I show you the data later on. These are family support partners with lived experience, having cared for a child who's gone through the system. And these family support partners received education on trauma. They consented to participate in evaluation. And I'll go to the next slide here.
Hi, Arabella. It's been asked if you could just speak up a little bit. That would be great.
Okay, thank you. So the next one here is local evaluation data collection instruments. So these are the instruments that we use: the enrollment and demographic information, the traumatic event screening instrument, which was given to caregivers only, the lifetime incidence of traumatic events, and we had a parent and a child version, so we were able to ask it of both, and the trauma symptom checklist, and there were versions for young children and for youth. So those are the tools that we used. Next slide, please. And here's the methodology. So child and youth trauma events included those that the parent or youth report having occurred and B, bother the child or youth a lot. And that's the important part. We're not just talking about that you've had a traumatic event, but we're talking about that you've had it and it's bothering you a lot. And that's actually the language used in the tool. The next one here is descriptive and correlative techniques, results of which were tested for statistical significance, and that we had 2 groups, youth with trauma and youth who had not experienced trauma. We wanted to compare that, and that we had another group, two more groups, and this was to incorporate measures of childhood trauma experience of primary caregivers. So we wanted to also see not only those adverse childhood experiences that children had, but that their parents or caregivers also had, and that was very important, and you'll see that data in a second. Next slide, please. So here's the characteristics of our population. It's 120 children and youth. The average age is 10, 61% of them boys, 92% of them lived at home. And then we had 117 caregivers, 92% of them were female, average age 36, 82% were the biological parent, 81% were high school graduates or higher, and 70% earned less than $50,000 per year. So I want to draw your attention to the chart here, and I think back to 15 minutes ago when I talked about those diagnoses that you tend to see with this population. Well, lo and behold, 54% was attention deficit. So it pretty much supported the research out there that what you often saw with youth who had experienced trauma was a diagnosis of attention deficit hyperactivity disorder, followed by mood disorders, followed by oppositional defiant. The next one is post-traumatic stress and acute stress. However, these are the symptoms. So they don't qualify for the actual diagnosis, but these are symptoms of PTSD. And then there's anxiety disorders, adjustment disorders, impulse control disorders, and the list goes on. Next slide, please. The next one here was child and youth trauma experiences. The most frequent type of trauma experienced by youth themselves is parental domestic violence, and that was one of the polling questions, and we saw a vast majority click on that one. More than 1/3 experienced physical abuse, and 1 in 5 had experienced sexual abuse. Many also reported experiencing having witnessed a bad accident, the death of a family member, having a seriously hurt or sick family member, or having parents divorce or separate. And although not pictured here, 9% had separated from their primary caregivers. Next slide, please. So symptoms of trauma in children and youth. So these are the symptoms here. So youth who have had more trauma experiences in their lives display significantly more symptoms, such as depression, anxiety, anger, and post-traumatic stress at the beginning of services. And then the second bar there shows youth trauma symptoms by the number of youth trauma experiences. So we know that if the youth has experienced 3 or more traumatic experiences, they're more likely to experience symptoms of depression, anxiety, anger, post-traumatic symptoms, dissociation, sexual concerns. Next slide, please. Effects of trauma on children and youth here. So on this particular slide here, and I apologize for the numbers overlapping, my evaluator couldn't get the numbers to get smaller, but what we see here is, again, the darker shade of blue, at least it looks blue on my screen here, less than 3 traumatic experience versus more than, and you can see, again, it bears out. The more traumatic experiences you've had, the more you're reporting anxiousness, depression, withdrawal, somatic complaints, social problems, attention deficit, rule-breaking behavior, aggressive behavior. So, next slide, please. Childhood trauma experiences of the caregivers. We wanted to find out from our caregivers what they'd experienced. And they reported having experienced at least 1 traumatic event before the age of 18, while 38% reported having experienced 3 or more. Some of the most frequently cited included emotional abuse, being separated from caregiver, sexual abuse, each showing up in over 40% of the caregivers. Next slide, please. So this particular one here had to do with caregiver strain, and there was actually a tool that was part of our national evaluation where we administered what's called the Caregiver Strain Questionnaire, which asked questions about the stress levels of caregivers with a score ranging from 1 to 10. And the higher the score, the more stress the person is under. So again, among caregivers who have experienced high levels of trauma, the average score was 8.4 compared to 7.5 for those with less childhood trauma. So not a huge gap there, not what we would consider statistically significant, but we wondered if we were to continue to ask these questions, our evaluation is closed at this point, if we would continue to see a broader gap between those numbers. So it suggests here that trauma histories may contribute to higher stress levels later in life, and we see the same thing with the physical health. So the importance of this slide, I know when we presented this data to our governing council, and we had 2 directors of family organizations there, and they saw this information, they thought to themselves, our work has just begun. It's important for us. We see that youth are getting better, yet the caregivers are reporting high levels of caregiver stress. So what can we as family organizations do to support families, to really get families to begin to recognize the impact that those adverse childhood experiences have had on themselves, both personally and as a parent. And that was very exciting for me because, again, it took it out of the realm of that clinical provider world and really brought it back to those family organizations and also to our youth organization to find ways to effectively partner with their peers and get this message out there. All right, next slide, please. And I'm actually going to probably skip through some of these slides, but with this one here, I just want to showcase the fact that if you, the left part says parenting youth, and then the right part says youth. So it's exactly the same in terms of the categories there. But the reason for this is that we see that these are youth that have experienced traumatic events and parents that have experienced traumatic events. So we can, whereas the right side is the youth only. In other words, the parent caregiver has not experienced, has not reported a traumatic event. So again, we see that youth, by and large, are reporting an increase in those symptoms compared to youth who have a parent that hasn't had a trauma experience. So we can sort of hypothesize here that that intergenerational trauma impacts the way that a parent is able to parent in a household. When you look at that caregiver stress, you know, and how perhaps they're being triggered themselves and how being involved with child welfare, juvenile justice might be bringing up their own baggage compared to a youth who has parents that don't report that sort of history. So that's really important information. Next slide. And same thing here. I'm going to go to the next slide just for the sake of time. And we're looking here at the symptoms after 6 months. So we're seeing that by and large youth have improved in terms of those symptoms that they had presented with within 6 months' time. Next slide, please. So some conclusions and implications here. Children and youth who experience trauma and exhibit trauma-related symptoms often do not have a PTSD diagnosis, and that trauma experiences of parents and or primary caregivers appear to affect youth symptoms as well as overall family functioning. So again, the importance of looking at the entire family, and that those trauma-informed family peer support partners seem to have a positive effect on the symptoms there. So, all right, so we're going to go to the next slide, and I'm probably going to skip a lot here. This essentially has to do with how we've sustained our work. So we knew that it was important that we wanted to provide that trauma-informed education, that we wanted to really look at it in a broad manner, that it wasn't just about the provider. However, we also wanted to look at the provider. We wanted to find out, how do you know if you are trauma-informed? So if you go to the next slide here, what we did is we created a tool, and again, go to the next slide, please. And actually the next slide, and the next slide, and we'll stop here for a moment. So we created a tool. We created it with family and youth and providers by our side. It took us 2 years to create it. It's considered a statistically valid tool that is now in state contract language, that has been administered twice here in the state of Maine. And it's a two-pronged assessment. What we're doing is we're measuring those key trauma principles across the 6 domains that I described earlier, and that we're gauging a level of trauma-informed approach to services from 3 perspectives. We're asking agency, staff, and when I say staff, as I did previously, we're talking about the receptionist, the office support, maintenance, record room, case managers, clinicians, psychiatrists, executive director. We're asking all the staff in the agency. In addition to that, there's a family questionnaire. So families are asked questions as they pertain to those domains. And then there's a youth questionnaire. And youth as young as 12, I believe, have completed that questionnaire. And that's the youth questionnaire. Next slide, please. So this gives you those trauma-informed principles that I described earlier, and it defines them for you. And then the last column there is how to assess those trauma-informed principles. So this is a tool that's provided to agencies that help them sort of look at that and look at what's happening here. And there is also a guide available on our website. It's an organizational guide to creating a trauma-informed system. It's specific to mental health systems. And it's about 32 pages long. And under each of those principles, it will actually give you some practice standards. And it's not by any means as exhaustive as it could be. I'm sure there's a lot more that we can put there that would be very culturally specific to each community. But it gets a good start. And there's actually, at the last part of that organizational guide, are actual statements from family and youth specific to these principles and what the system could look like if it were trauma-informed. And that's very exciting for us. Next slide, please. This is a statewide implementation. We first administered the agency assessment. It was available online. Also, we had it available to family and youth as a paper form that they could send in to us with stamped self-addressed envelopes, or agencies would do the stamped self-addressed envelopes. They could also call. We had an 800 number available with our evaluators where family and youth could call and actually give their responses. And again, all of it was anonymous, and the information could then be tabulated. So it was administered in 2010, and you could see how many actually completed it, and then it was re-administered again in the summer of 2011, and you could see the numbers that completed it there. And the results were then generated back to agencies. Next slide, please. So here you see statewide results. So as a state, and we have 142 agencies that contract with children's behavioral health services. And when I go back and I look at the previous slide, with the first cohort, we had 75 agencies completing, and in the second one, even though it's a 61, they may have been duplicates. So we're not, I mean, I don't have it in front of me, but I do believe not all 142 have completed the assessment. But we have a good number that clearly surpasses the 100 threshold. So here you could see the aggregate data. So for the first domain, what's interesting here is that physical and emotional safety, family rated higher. When you look at youth, there's an X on family because the family did not respond to the youth questionnaire. It was specific to youth. Whereas family, one right under that, you have an X by youth. So for youth empowerment, youth report lower. For family empowerment, family report a little lower. Under trauma competence, family reporting higher, youth are reporting, actually agency staff are reporting lower, which makes sense because the staff would really know how much education are we really getting on trauma and how effective are we. So this really gets at their own professional development if an agency is tending to that. The next one's trustworthiness, and low score there for our young people who aren't trusting the system. The next one's commitment to trauma-informed philosophy, and it's X'd out for family and youth because that trauma-informed philosophy, again, is information that only an agency would know about. It's really specific to their policies and practices around HR, orientation, grievances. So it's not information that family and youth are privy to. They might see it in action but not know what it is. And we see a very low score there for agency staff. And the last one is cultural competency and trauma. And agency reporting very low numbers that they think they could do a lot better. So it's exciting to see when agency staff see room for improvement. When we looked at this data, our youth all looked at it and the providers all looked at it, and the providers almost unanimously said if we have to pick one goal to work on, it's going to be youth engagement. Clearly, we have a ways to go with being a youth-guided system where you feel that they're provided with opportunities for choice and empowerment and trust. All right, next slide, please. Here's the contract language, and there's a hyperlink that you can go to see the entire contract language, but this work would not have been possible without the state leadership from Children's Behavioral Health Services, where when we first were funded, 2 years into it, recognizing that if we really want to be intentional about this needs to be in contract language, and agencies need to have a tool to be able to assess how trauma-informed are they. And the tool was always meant to be a tool that would assist them in developing a training plan, a CQI plan that was data-driven. So it wasn't them guessing whether they were trauma-informed or not, but using actual data and using it for their benefit. So not meant to be punitive, but really meant to be something that would help them in the developmental process. Next slide, please. On the next slide, you can see the CQI process, but I won't go into that. We'll just go to the next slide. And the next slide is a sample report card from an agency. This is an actual agency, and this is their scores. And this particular executive director, when he got his scores, his reaction to that was what I said earlier, which is I want my agency goal to be on youth engagement. I think that we have a ways to go. So looking at this, then what he was able to do was to create a youth advisory council to meaningfully engage youth in a conversation about what their experience of services had been like to date and how they could improve. Next slide, please. And here, this is my last slide here, so I'm going to end with, really the importance for me anyway, when I think about being trauma-informed, I think about providing education to all, so that it's not just about the provider agency, but it's about teachers, law enforcement, churches, judges, and I could give examples of how we actually have done that. We've done book clubs in schools with educators using a particular book that came out of Massachusetts around the impact of trauma on learning and how to create a trauma-informed classroom setting. The teachers love that. You know, they were able to reflect on their own experience teaching children that they knew something was wrong, but they couldn't figure out what it was. So giving them this language allowed them to put it in a context that made sense and that gave them the tools that they needed. And the same, I could say the same when it came to working with juvenile justice and working with our judges and working with community members to be able to all be aware of the impact of trauma. And then for me, probably the most exciting piece was to also see how our family and youth organizations took this work on and ran with it. They were able to reflect on their own trauma histories and how they hadn't been asked what was wrong. That it always had been about, it hadn't been about their story, it had been about something being wrong with them. So it was important for them to be able to in turn model that and be those trauma-informed champions. So that ends my presentation. Thank you.
Thank you, Arabella. That was really wonderful. So now we can open the lines to questions. If you have a question, please press *7 on your phone to unmute your line. And we have a question submitted through the Q&A function, and the question, I'm guessing this is for Arabella. Are your trauma assessment tools available for use outside of Maine? If so, how can I obtain some?
Thank you. Our trauma-informed dignity assessment is available outside of Maine. I would encourage you to contact me. My contact information is on the last slide. You'll see it there. It's a tool that we're still collecting data on. So what we've done is we've created a licensing agreement, and we're working with 2 states in particular now who are actually using it because there is an education technical assistance component to this. So there's a process involved in that, and I'm happy to have that conversation with you. It's available on our website. You won't find it. You'll find that organizational guide that I mentioned earlier, and the way to access that organizational guide is if you go to our website, thriveinitiative.org, you'll actually go to a training tab, and you'll log in to see one of our webinars, and those webinars are free of cost. And those webinars actually go further into those principles. We have one on the principles. We have one on what it means to be youth-guided. We have one on family-driven. And once you view the webinar, you actually then get to download the guide. And it was, again, really important for us to be able to track who was downloading that guide. And it's really exciting to see people as far away as Australia actually participating in our webinars and downloading that guide. So that's really exciting. I encourage you to contact me.
Okay, great. Timothy says thank you. So we have another question. How do we get a copy of the PowerPoint? I'm assuming that we're talking about this PowerPoint, and it was available in the instruction email, but it'll also it can be sent out again. So it will be available, and also the entire recording with the PowerPoint, the presentation, will be on the TA Partnership website. And now we can go on to the next question from Cheryl. The question is, will contact hours be available for participants? Cheryl, I'm not quite... No.
No, we don't want the CEUs with you.
Okay.
No.
So any other questions? Press *7 on your phone to unmute your line. Okay, it looks like we do not have any other questions, so Karen Francis is going to take the lead.
So thank you, Allie. Prior to the webinar today, as you registered, many of you submitted questions online. Quite a number of questions actually we received online prior to the webinar. So Arabella and Ingrid, if you'd just bear with me for a few, I'd like to read, probably 1 or 2 of these questions and for you to provide some response. And then because, again, as I said, there were so many questions, what we have decided to do is to, after the webinar, we will be able to respond to these questions and send out a follow-up fact sheet with responses to some of the questions that were asked prior to this. But I'd at least like to take the opportunity, to at least see if we could address one or two of the questions that were asked before. So the first question here is, how do we apply the information, this information that we've learned here today from my local community? How to deal with cultural barriers related to class and poverty, as it really, with a focus around trauma-informed care. Arabella, Ingrid, you want to?
Karen, can you just repeat the question, please?
Yes, the question is how to deal with cultural barriers related to class and poverty. And I'm assuming here that the question is looking at poverty as one of those aspects of trauma that provide or produce trauma.
Hi, this is Ingrid, and I'm just going to weigh in very quickly. And I wanted to draw the person who asked the questions. I want them to go to the National Child Traumatic Stress Initiative's website, nctsn.org. Well, they will find a plethora of resources to address all sorts of different trauma-related issues, including those very specific issues. They should be able to find fact sheets, guides, evidence-based practices that will help in dealing with those particular issues.
Okay, thank you so much for that response, Ingrid. And then I see we have 2 minutes left. So in those 2 minutes, I'd just like to ask one more question. Okay, and that question is, how can we as an agency gain an understanding of the increasing refugee population in our area and subsequently offer services and support through our agency?
I'd like to answer that one here. This is Arabella. Here in Maine, we have a growing population because we're a primary and secondary resettlement site, and it's been very interesting to see the communities that have been growing here, primarily communities from Africa, from Eastern Europe, from Asia. Here in Lewiston, the population is significantly Somali. In Portland, you'll see Sudanese, Somali. And one of the things that we did early on was to work with cultural brokers. And they weren't called cultural brokers. It was really ethnic self-help organizations. For instance, we have the Somali Bantu community, Stengo Vos for Latino women. We have the United Somali Women of Maine. And these are just self-help groups that sort of just organically come about, really wanting to preserve culture, find activities. Stengo Vos and the United Somali Women of Maine, their focus was on domestic violence, so wanting to provide that education. What we knew, and I think it still holds true to date, is that our refugee communities weren't going to access services in the traditional manner. And many that tried, for a variety of reasons, it just didn't work for them. So instead, we found that providing education to the community, going to them instead, and working with those leaders, whether they were formal and informal leaders and the elders, was really important because they then could do that work in that informal peer way. And that can be just as effective as receiving services, because oftentimes it's that peer-to-peer support that gets them through the door to services when they're ready to enter services. So I can't stress enough the importance of working directly with the community instead of trying to create a system for them, but really working with them to sort of figure out. And again, if you were to talk to our refugee community, by and large, what they would say, it's the educational system. That's the system they struggle with. So again, listening to them and not assuming that it's because of the trauma and the mental health symptoms, but listening to what they have to say, which really had to do with the educational system.
That's great. Thank you, Arabella. Before we wrap it up, I want to draw everyone's attention to an evaluation that we have. So we'd love to hear your comments on this event and what you'd like to see in the future. After the presentation, that's this. You're directed to the short evaluation. If you're participating on by phone today, you will also have an opportunity to fill out this form in the follow-up email.
And then also before we close this afternoon, I'd just like to call your attention to an upcoming event that's being scheduled through the National Association for Rural Mental Health and their conference on May 15th in Anchorage, Alaska. They will be sponsoring a learning exchange. This learning exchange is intended to provide participants with an opportunity to visit programs in Alaska, in particular the Alaska Psychiatric Institute, as well as also visit virtually through video conferencing several other programs within the state of Alaska that are implementing innovative services and practices for children with behavioral health needs and their families, all focused around rural communities. And then following these site visits as well as the video conferencing, then participants will be given an opportunity to engage in some facilitated discussion, really to engage in facilitated discussion around offering some opportunity to reflect on experiences that were gained through these site visits, as well as to talk about some identified strategies really to apply to your own settings within your own communities. For further information about the learning exchange, Ali, if you could just go to the slide with that. Please visit the registration website for the National Association of Rural Mental Health, and we have the registration website on the slide in front of you now. So please visit that website for additional information about how to sign up for the learning exchange if you are interested in participating in it. And we'll also have information about the learning exchange and some of the information gleaned from the learning exchange that will also be posted on the Technical Assistance Partnership website post the actual exchange event. So once again, thank you all for joining us this afternoon for this very important webinar, and we do look forward to your participation in future rural behavioral health webinar sessions. Thanks again.